Tēnā koutou katoa. It's almost Easter already, then just 9 months till Christmas. However, this evening's delight is brought to us by Dr. Kate Coffey. Kate is an obstetric and gynecology consultant and a senior lecturer at the University of Otago in women's health. Kate works clinically in Invercargill as a generalist obstetrician and gynecologist at Southland Hospital. Then her university work is based in Dunedin. Tonight, Kate joins us to consider obstetric emergencies, including postpartum hemorrhage, cord prolapse, and maternal sepsis. Along the way, feel free to use your chat function to introduce yourself, where you're from, and what your role is. If you change your settings to all panelists and attendees, this means that everyone else can see who's joined us across New Zealand tonight too. And any questions you have, feel free to put them in the Q&A tab and we can address these at the end. And so without further delay, I shall hand you over to Kate for this evening. Thank you.
Hi, good evening, everyone. So I'm Kate Coffey. I'm a consultant obstetrician and senior lecturer in the south of the South Island. So I live in Dunedin and work in Invercargill 0.5, and I lecture at the University of Otago in Dunedin. So tonight I'm going to be talking to you about obstetric emergencies in a rural setting. And I have to confess that the most rural that I've ever been in New Zealand is Invercargill, so that counts as a rural training site for Ranscog, but it is a tertiary hospital, so it's not really rural in many ways. I did work in Labrador in Northern Canada as a medical student, so I have been to more rural places, but again, that was in a hospital setting. So some of you will work very rurally indeed, and some of you will work in very small practices where you don't have access to many other people to support you. So I'm aware that some of the things that we'll talk about will need to be very individualized for some of the places that you're working. So what we'll cover today, initially I was asked to give this talk, and I think the people who were receiving it were in Greymouth, and I asked them to send a list of what they thought we should cover in obstetric emergencies, and this list is what they sent to me. And so with only an hour, it wasn't realistic to do everything. So I've picked cord prolapse, shoulder dystocia, unanticipated delivery, PPH, and maternal sepsis, which I'll cover very briefly at the end if we have time. A little bit about me. So I am married to Sean, who is a cardiologist, and we have 3 children, Kira, who is 12, Aisling, who is 10, and Oscar, who's now 6. And this is them on Oreti Beach in Invercargill when I was doing my rural registrar training. And this is how my secret weapon, which is my mother, Marilyn, and our good friend, Maureen, who is an orthopedic nurse, and her daughter is a surgical registrar, and they're very much part of our whānau as well. And when we lived in Invercargill for the year, Mum rented Maureen's daughter's house, and that's her on Doon Street in Invercargill. And so these are the things that people who live and work rurally or are in training have to do. You move your entire family somewhere that you've never been, and there are lots of hidden costs to a lot of the things that we do when we provide healthcare in places that are difficult to get to. I'm Canadian originally, you may hear my accent, and I went to medical school in the UK, and we came to New Zealand in 2007 for a year of OE, and here we still are with 2 Kiwi children, and Oscar was born in Oxford when I did my PhD there, so the girls tease him that he's not a proper New Zealander, but he's lived here for most of his life. So emergencies are scary, they're unpredictable, and you really need a team to deal with them adequately. And sometimes where you guys are working, the team will be you and maybe the dad or a passerby. Or I worked with a midwife who worked at Waitakere Birth Centre, and she had the porters or the hospital orderlies who would help her if there was an emergency. So when she practiced scenarios for resuscitation, for instance, the hospital orderlies were the ones who would do the chest compressions because they had been trained to do that. And she had one other midwife that usually would be there when she was having a birth, and no other healthcare practitioners available to her. So one thing to do after tonight is whatever your specialty, and I understand from the list I've seen that there's lots of people who are not particularly allied with O&G, is think about emergencies that could arise where you work and who will be in your team and what you'll have them do. Ideally, you need to think about what you would do in a certain situation before it happens, because that way you may already have a little plan about what resources are available to you and what you would do. Unfortunately, most emergency sort of flow charts or algorithms really are based on what we have available to us in tertiary level hospitals. And that's not the case for many rural practitioners. So things do need to be individualized and localized. One advantage that you might have if you're working rurally is that you'll probably know your team and your resources very well, because you might be the one who has set them up or worked with them for a long period of time. So that can be an advantage. Something that's super important in a rural setting is documentation. And that's important for anyone, even in a big tertiary hospital in an emergency. The things that are really important to document are any drugs that have been given, what dose, what route, and what time they were given at. Even if it is on a scrap of hand towel, and you will some people are going to be chuckling right now, because we've all seen the little hand towel in someone's pocket, especially midwives, with the obs on them or the medications that have been given. And if you documented on a non-standard piece of paper, then just stick it in the notes. That should go in the clinical record. If you have time, you can rewrite it if you want, but it's absolutely fine to put something in the notes. But super important for when the patient gets to wherever they're going, that the person who's next looking after them has a good awareness of what happened. Things that can get lost when patients move is blood loss. So, you might think if you were at the delivery and there was literally, blood up to everyone's eyeballs, or the back of the ambulance needed to be mopped out after the woman left it, it might seem really obvious that that has happened, that there's been heavy blood loss. But when someone arrives, the first thing that health staff do often is clean someone up. And so they might get quickly showered, or all the dirty linen might get tucked away, and that part of the story can get lost. So really crucial to document and to make sure that important things are handed over. And use local resources. Again, you may not be able to do what the algorithm says, but you may be able to modify it for what you've got. And sometimes family members might need to be the ones that are writing things down, and you might just have to get them to write things phonetically, but really important in an emergency that things are getting captured. Something that we do in our birth rooms in Dunedin is that they have whiteboards in the rooms, and we write doses up on the board, and then someone will take a photo of that with their camera and email it to someone to have printed out and put in the notes. So even things like that can be useful. So the first emergency that we're going to cover is fortunately pretty rare. Chord prolapse is descent of the umbilical cord through the cervix in the presence of ruptured membranes. So that's a frank or overt chord prolapse. But as with many things in medicine and healthcare, the same person can go through a few different stages of a presentation before it declares itself. So sometimes you might do a vaginal examination on someone and feel something squishy next to the head that shouldn't be there. And so that could be an occult chord prolapse, which is where the cord is palpable, so you can feel it next to the presenting part. It can be overt, where it's palpable or visible and is beyond the presenting part, or it can be a chord presentation, which is sometimes seen on ultrasound scan. And that's when the umbilical cord is close to the cervix, often below the presenting part, but hasn't yet passed through it. And often that's because the membranes are intact. We had a very sad case in a rural center that was allied to Dunedin, where a woman had had a number of growth scans, and cord presentation had been noted on each scan. And the plan was for her to come and deliver in a tertiary center, but she was a multip. I think it was her third or fourth pregnancy, and she went into early and rapid labor, and actually did sadly have a chord prolapse in a rural center and lost the baby. So these things can happen really suddenly. Knowing about them and preparing for them doesn't mean that we can always prevent them from happening. So this is an illustration from a textbook, and this shows the different styles of chord prolapse that you can have. So this would be a chord presentation or an occult chord prolapse. So you can see the pelvic bones here. You can see the vagina here, and here's an open cervix with cord poking down just above the intact membranes there. So if you felt that on a vaginal examination, you'd feel something spongy and maybe something pulsating and a feeling that you couldn't quite get to the head. This is an overt chord prolapse, and you can see a loop of cord that's coming out that might be visible at the introitus, and it might not be. And this is one, so a breech presentation, we'll come to that shortly, is a risk factor for chord prolapse, mainly because you can see here with the cephalic presentation that a nice smooth head that's in a good position acts like a cork in a bottle, or I think of it as like a plug in a sink, and it really plugs the hole. And whereas a bottom may not completely occlude the cervix, and so the cord can sneak down past that bottom. So chord prolapse is an obstetric emergency, and that seems trite, but it is, when we sit our exams for obstetrics and gynecology and in other specialties, one of the things that we're trained to do is to say, this is an obstetric emergency. And I think, while you might not feel that it's appropriate to do that in a room, if there's just maybe you and the mum and dad, just have a think about that, because actually it can be helpful to declare to everyone who is present that there's something going on that's urgent and is beyond the realm of normal. And people are always worried about overcalling something, but I've never been in a situation where I've regretted escalating things, because you can always de-escalate very quickly if you think there's an emergency happening and it all settles down. So anyone who works in obstetrics will have had a situation where a fetal heart rate drops and it's a bradycardia and it resolves, and everyone's rushed in to help and things get better, and you can just gently scoot everyone out of the room. Something else that commonly happens is someone who's lacking in a bit of confidence will say, should I push the emergency button? And that can happen in many settings other than O&G. But the answer to that question I try and drum into all the students and the TIs is, if somebody asks that question, the answer is always yes. And it's because if you've had that thought that this is a really big deal and something bad is happening, you're far better to get help on the way in case you're right, because you can always send them away again if things resolve. So chord prolapse is generally unexpected, but like most emergencies, can be anticipated. It's much more common if you've got an unstable lie, so where the baby has been cephalic one day and then transverse the next day and breech, and every time you palpate them, the baby's in a different lie. And the reason for that is that when the membranes rupture, if the baby is not in a longitudinal lie, then the chance of something blocking the exit for that cord is much lower. More common with a malpresentation, so if you've got a bottom or an arm or a shoulder. Much more common with polyhydramnios, so when you've got excess amniotic fluid. And the reason for that is just hydrostatic pressure. So if you've got a big bag of water under tension and those membranes rupture, so someone ruptures them with a hook or they rupture spontaneously, the pressure of that fluid will have a much higher chance of dragging the cord out with it. And also there's a higher chance of the baby bobbing around in all that fluid and not being in a long lie. Multiple pregnancy, there's 2 kids, 2 cords, more likely to have a malpresentation. And if you have a high presenting part, again, lack of something plugging the exit hole. It usually happens at membrane rupture, and it can be spontaneous at ARM. When we're applying a scalp clip, so a little clip onto the baby's head to monitor the baby's heart rate. Sometimes we can actually dislodge the baby's head a bit when we're doing that, and that would be a time where the baby's head can go up and the cord can come down. Or during manipulation of the baby. I've never actually heard of that happening, but it's in the books. And during delivery, it can occur. People are often nervous about rupturing the membranes, especially if there's a high head or polyhydramnios. But I would urge everyone, if you are a core midwife or an LMC and you're working somewhere where there are other healthcare professionals around and there's access to theater and things like that, definitely think about it. And maybe if you're a midwife, chat to the reg and say, oh, I'm thinking of rupturing the membranes and I feel like the head is a little bit high, I'm a bit nervous. But whoever is using the hook on the membranes of that woman, or if the membranes rupture spontaneously, if the cord's going to come down, it's going to come down whoever is doing it. So it's nothing to do with the skill of the practitioner. Right? I think the only situation in which there would be any criticism would be if you recognized it was a high head and there was polyhydramnios and you were somewhere very far from any assistance and you went ahead and actively ruptured membranes and something bad happened. People might ask some questions about what you were thinking in terms of that risk. But if you're somewhere and someone is having an induction of things, don't be afraid of it. It's something that can happen, but usually it can be managed. So the principal thing is to recognize that it's happened. So if you can see the umbilical cord and the baby is not out, there's a cord prolapse. If you can feel the cord in the vagina or feel the cord in the cervix, there's probably a cord prolapse or an occult cord prolapse. And if there's a sudden change in fetal heart rate, especially around the time of rupture of membranes, then you need to do a vaginal examination to check whether there has been a cord prolapse. Right, so the first thing that ONG registrars or SMOs will do if we get called into a room where there's been a sudden deterioration in a CTG is to do a VE, and we do that even if someone has just done one 5 minutes ago as a routine part of planned care. And that's because a sudden change of heart rate can be one of the cardinal signs of a cord prolapse. So there are two principal CTG changes that are seen with cord prolapse. One of them is this one, which is regular deep, what are called variable decelerations. So the baseline fetal heart rate is normal in the CTG and it's about 140 beats per minute, which is in the normal range. The baby has normal beat-to-beat variability, but every time there's a uterine contraction, the baby's heart rate drops significantly and recovers at the end of the contraction. So these are called variable decelerations. They're quite scary to hear. And they're a bit scary looking when you first start out, but they are pathognomonic of cord compression. And of course, when there's a cord prolapse, if you've got the open cervix here and the cord is poking down and the uterus squeezes, that cord is going to be completely occluded every time there's uterine contraction. But when the contraction is released, then that pressure on the cord is released and the baby becomes happy again between contractions. So about half of the time, this is what a cord prolapse CTG would look like. And what we do know is even though the baby's recovering beautifully in between these deep decelerations, after a period of time, that compensation and that recovery will start to wane and the baby will become deeply unhappy. And so this is what we tend to think about more typically as a CTG associated with a cord prolapse. Again, the baseline heart rate was 140 prior to the cord prolapse, and something has happened here. Where's my little mouse? Here. Probably the cord whooshed out with a bunch of amniotic fluid, and the fetal heart rate is 60 and will drop below that and has never recovered in the CTG. So if this baby is not delivered urgently, then this is a baby that will succumb because of the cord prolapse. So this is a CTG we never want to see. This is why it's a problem. So I think of the baby as being like an old-fashioned scuba diver. And this old-fashioned scuba diver was very dependent on the person with the oxygen pump up on shore. And the umbilical cord carries the oxygenated blood to the fetus. And if it gets kinked, or if it's in the vagina or exposed to air, the vessels in the cord go into spasm and the blood supply, the oxygenated blood supply to the baby can be completely cut off. And so there's no air. So what we can do to help is use gravity or pressure to help us. So we get the presenting part off the cord as quickly as possible. So LMCs who have a woman who's known to have polyhydramnios or known to have an unstable lie will typically explain emergency measures to the woman, and will say, if your waters break and you feel something come down, then get into a deep knee chest position. And I've got a picture of that on a subsequent slide. If you're with the woman and you're going to be transferring her and she's on a hospital bed or a stretcher, you put her into deep Trendelenburg, so a steep head down, as steep as you can get. And if you are somewhere where you need to rush her on a stretcher, but you can't do a Trendelenburg, then the person who's with her, so birth attendant or a GP or a nurse or an ONG person, can do a vaginal examination, put your fingers in the vagina and push the presenting part of the baby up off the cord. So typically that would be a head or a bottom. And you're literally just trying to prevent that squeeze of the bony head onto the cord every time the uterus contracts. What's described in the books, and I've never seen it done in a real person, but we do discuss it on the prompt course, is that if you were coming from somewhere far away and you thought you might be in an ambulance for 3 hours, it's actually almost impossible to keep pressure on a presenting part for 3 hours with your hand. It would cause quite a lot of pain and potentially, I guess, muscle damage to someone's hand to do that. So an alternative is to fill the woman's bladder with 500 to 750 mils of fluid. So typically that's normal saline via a catheter and then clamp it. So you put a catheter in exactly as you would if you were putting it in for any other reason. And then and you fill the balloon exactly as you would normally. And then through the channel that normally drains the urine out, you take a catheter tip syringe and you squirt normal saline into her bladder. And you squirt in, if you had a 60 ml syringe, you're going to do around 8 of those. It is very uncomfortable for the woman, I would imagine, and she will probably get quite distressed by the feeling. So she would need a lot of analgesia. But you squirt that in and then you put a clamp. So I've seen people use those disposable blue clamps, or you can spigot the catheter if you have one. And if you didn't have a clamp or a spigot, you could just fold it over and hold it shut, or put an elastic band around it, anything to occlude that channel from draining the water back out. You need to get the woman to where she can deliver. So if you're somewhere very rural, you may need to transfer her, even if it's going to be a long transfer. If you have tocolysis, you would give it. And typically what we use is terbutaline, 250 micrograms given subcutaneously. So that's usually injected into the leg or tummy. And you want to keep air off the cord. So it's a bit controversial what you actually do with that. But I've heard people describe, warm, wet swabs and things like that. But a warm wet swab is going to become a cold wet swab very quickly if you're having to move someone any distance. So actually the best things that I've heard of are to get some cling film or a clean plastic bag of some kind and gently replace the cord into the vagina and put the plastic thing over the opening, over the introitus, so the air to handle the cord much. It can cause vasospasm. So remember, the cord is a blood vessel for the baby. So this is a picture of the knee chest position. And so the woman's bottom is as high up in the air as you can get it. And that's just using gravity to try and keep the presenting part, which in this case is the head, off that loop of cord that's poking down into the vagina. And a woman could be doing this on the back seat of a car. Or she could be doing it on a trolley or in an ambulance or in a birthing center if you were waiting for a helicopter to come and retrieve her. This is a picture of the bladder filling, funnily enough, in the being used to fill the bladder. And I can't imagine giving set to the catheter. So anywhere that I've worked, I've imagined that I would do it using a catheter tip syringe, but it doesn't really matter. Anything that you can squirt the fluid in with is fine. And here you can see that they are clamping the catheter. And for some reason, I think they've shown some kind of like 3-way catheter, or maybe that's meant to be where you fill the balloon. This is an actual news clipping. And this was a Northland midwife who had to have her hand in the woman's vagina for 90 minutes. So this couple managed the Russell Top 10 holiday park. And I think they had to actually get on a ferry to get to where their midwife was. And the midwife then transferred them by ambulance. And you can see that both the woman and the baby did really well. And I think that she was a primip, so it was her first pregnancy, and she made it to the hospital and had a cesarean section. In the case, so you might think, oh, would it always need to be a cesarean section delivery? But if you've got a multiparous woman and she can push that baby out before you can get her to theater, that's fine. You just have to sort of play it by ear. And if you were somewhere and you had someone who is skilled to do an instrumental delivery and the woman was fully dilated, then you would consider doing that if that was going to be faster than getting the woman to an operating theatre. So it's always a very individual case-by-case assessment that needs to be made. The key thing with this and any of the interpartum emergencies is that you need to think about who's going to look after the baby once you deliver it, because you've got to anticipate that you may have a very flat baby born who needs significant resuscitation. And it might be that you have to look after the baby as well. So you need to be contingency planning for that, so that as soon as you've delivered the baby, you may need to delegate some of the woman's care to someone else while you resuscitate the baby. So I'm just going to, I don't think there are any questions at the moment. What I'm going to do is I'm just going to go on, and I'm happy to answer any questions that anyone has at the end. So please just write them down or put them in the Q&A if you've got any questions. So the next thing to cover is shoulder dystocia. This is one of the scariest emergencies. And the reason that it's really scary is because it happens very late in labor. And by the time it happens and you recognize it, it's generally too late to be anywhere other than where you are, and to get anyone other than who you have in the room to help you, unless you're lucky enough to be in a tertiary hospital with an emergency bell on the wall and pediatrics on site. So again, it's an obstetric emergency. It's something that anyone who's worked in obstetrics for any length of time will probably have seen. And fortunately, most of the time, most shoulder dystocias resolve with a couple of very simple maneuvers that can be done by anybody. So we're really fortunate. I think typically anyone who's experienced a bad shoulder dystocia will say that it's one of the worst things that they've ever been involved with. So it's an obstetric emergency. It's one that often people who are in the room watch unfold very slowly right at the end of labor. And often there's a lot of eye contact being made if you're fortunate enough to have more than one experienced healthcare provider in the room at the time that a woman is giving birth and a shoulder dystocia is unfolding. People will be doing the eyes at each other and start miming things like back of the bed down and get ready for the legs, and they might even sort of tap their shoulders. A shoulder dystocia is a bone-on-bone problem, and the bones that are involved are usually the woman's pubic symphysis, so the pubic bone under the mons pubis, and the baby's anterior shoulder bone. It's not something that pushing hard will fix. In fact, pushing hard might make it worse because the baby's shoulder is wedged behind the pubic bone. So extra force will not help. I think of it as a form of occult cord prolapse, because when the shoulder dystocia occurs, the baby's head is delivered and the baby's body is in the vagina, and often the umbilicus and the cord are in the vagina at this point. And so the cord is generally completely occluded. If you have a really long baby and the cord is still in the uterus and not occluded, you might be very lucky. And the baby might actually do really well and might not be having any major difficulty during the cord prolapse. But typically, it said you've got 5 minutes from diagnosis to deliver a neurologically intact baby. So recognition, again, is key. It's recognized at the time of the birth of the baby's head. And one of a few things will happen. Number one, typically, it'll have been a really long second stage. So typically, the woman will have been pushing for a long time, made slow progress. And from the time of crowning, where you can see good peeps of the baby's head, often that takes much longer than usual. So normally the baby crowns, a couple more pushes and the whole baby is out. And so people will usually recognize that a shoulder dystocia is happening, but we're always reluctant to make a pronouncement on these things, partly because we hope we're wrong. So what will happen is often the baby's head will be birthed very slowly, and it'll come out and it'll stop at some points that are atypical for the head to stop during birth. So usually the head comes comes, and just comes out. And then the baby restitutes and the rest of the body is born. With a shoulder dystocia, the baby could get stuck here or here. Sometimes the chin is not delivered. Sometimes the chin is delivered, but the head is very tight on the perineum. There's a thing called turtlenecking, which is where the perineum looks like a turtleneck jumper on the baby. And the definition is one where additional maneuvers are required to deliver the baby's body after birth of the head. The incidence is 1 in 200 deliveries, and about half of those will have recognizable risk factors. So there might be cases in which people have already said, oh, we're expecting a big baby, or she's got gestational diabetes, mom has a larger BMI, woman's had a shoulder dystocia, or someone commented that there were tight shoulders the last time. So there may be things that we anticipate, but half of them are in babies where they're completely unanticipated. So a normal BMI woman had previous babies with no issue, normal size baby, no diabetes. Everything's been pretty uneventful until the moment that the shoulder dystocia is recognized. There's a great mnemonic for shoulder dystocia. I think it was coined by the ALSO team, the Advanced Life Support and Obstetrics team, but it's been adopted internationally. It's one of the only mnemonics that I like in all of medicine. It is a little long. So my favorite are mnemonics that have 5 or fewer letters in them, because I find that easier to remember. But I do think this one is relatively easy to remember. So H is call for help. You want any help that you can get. Ideally, you need 2 people to help with the woman's legs, and another person to put the back of the bed back, and someone to take the baby when it's born. So you want as much skilled help as you can get. The E is evaluate for episiotomy. If you haven't already done one and the head is out, it is very difficult to cut an episiotomy. So really, that E probably should come before the help. It should be a helper, and you should evaluate for episiotomy in cases where you suspect a shoulder dystocia might be likely. Legs into McRoberts, and I've got a slide of that. It's basically extreme flexion of the knees and hips, and a knees to nipples maneuver. P is for suprapubic pressure, and that's applying pressure above the pubic symphysis over the back of the anterior shoulder. E is for intermaneuvers, and these all have names which are not important, but I've got some pictures of how you do them. R is for remove the posterior arm, and it used to be suggested that you remove the posterior arm by putting your fingers in vaginally, getting the hand and sweeping the baby's hand over its face. Actually, what most people do now is deliver the posterior shoulder, and I'll talk about that at the end. The last R is for roll onto all fours and repeat, and that's called the Gaskin Maneuver, and is named after Ina May Gaskin, who was a midwife on a commune called The Farm in the US, who wrote a really beautiful book called Spiritual Midwifery. And one of the important things about this mnemonic is that although it has an order, you don't have to do the maneuvers in order except for the first 4. So you obviously call for help straight away. McRoberts and suprapubic pressure should be the first things that are tried because they're the least invasive. But all of the other things can be done in any order. And if you were at a home birth or you didn't have anyone to help you do McRoberts, then you might onto all fours straight at the beginning. Quite difficult to do that with someone with an epidural, but I've been told not impossible. So there we go. So this is a picture of what a shoulder dystocia looks like, so that you can see, there's the introitus, the baby's head is out and the baby's neck and shoulder is still in, and the umbilical cord is still in. And this is showing you what not to do. So basically, if you try to deliver a baby's head and normal maneuvers to deliver it, basically supporting it as it comes out, are ineffective, you should take your hands off the baby. It's very difficult not to pull on the head, which is what they're doing here. What this picture illustrates is that if you flex the head downwards, you're putting pressure on the baby's brachial plexus, which can result in nerve injury, which can be permanent. So it can be quite serious. And in really serious cases, it's possible to cause bony injury to the cervical spine, which could be fatal. So don't pull on the head. This shows here how the baby's shoulder is impacted on the pubic symphysis. Typically, that is the cause of shoulder dystocia. It's theoretically possible to have shoulder dystocia that's caused by the posterior shoulder impacted on the sacrum, but that's much less common. all about physics. All of obstetrics is about physics. And so what's happening in a shoulder dystocia is that the bisacromial diameter, which is acromion processes, which are bony points, is too large for the woman's bony pelvis. And so what you're aiming to do is either to shift the bisacromial diameter. So if it's impacted here, you want to move it so that the bony shoulder is no longer under the symphysis pubis, or you want to reduce the distance by making the baby flex its shoulders like this. So if you're doing McRoberts maneuver, that opens the pelvis out, so to increase the bony. If you're doing suprapubic pressure, be shoulder to try and get the baby to do this. So this is an illustration of the woman doing McRoberts. So a woman, of course, can do it herself. So if you are at a home birth or in a birthing center or on the floor of your office in Wanaka, which can happen in rural, they're really not meant to give birth. It can happen anywhere. It can happen in a car. So a woman can do that anywhere herself. But if you have helpers, then you can get a helper to take a foot on each side and they can help to flex and abduct her knees and hips. This is showing suprapubic pressure. So someone's putting pressure on the anterior shoulder from behind through the woman's abdomen. It's not comfortable. And if you've seen it done well, it's assertive. So the first time I ever saw a really good LMC giving really good suprapubic pressure, I was pretty surprised as a very young registrar at how assertive a pressure it is. But the baby's not going to waft out. So typically people who've been at shoulder dystocias and are doing proper suprapubic pressure are up on the bed with the woman and really hoofing down on that shoulder. And in the heat of the moment, you might need someone to give guidance as to which way they should be pressing. Because it's not always obvious. And in this picture, the baby, it's obvious which side the baby's back is on. Quite often these babies don't restitute. And so the head is pointing downwards and you can't tell which side the shoulder is on from looking. So the enter maneuvers all involve putting a hand into the vagina. So the reason it says to consider an episiotomy early on in the piece is not because that's going to do anything to assist the bone-on-bone problem, right? You could do 5 episiotomies. And if there's bone-on-bone impingement up here, a cut down here is not going to do anything. But it will help the person who's trying to help the baby get out put their hand in. And so what it does is decreases the chance of severe maternal trauma from bad tearing, from having a child and an accoucheur's hand in their vagina at the same time. When you're putting your hand in to help, you have to go in posteriorly. If you're doing it on a model in a course, everyone wants to go in anteriorly because that's where the shoulder is. But it's not physically possible to get your hand in anteriorly because the woman's clitoris and urethra are there. The pubic symphysis is there. So you have to go in posteriorly and you have to do something called a Pringle hand. And so if you're doing any training in your units, get someone to take one for the team and eat a box of Pringles. And if you take a Pringles tube and try and imagine getting the last crisp out, that's what you do to get your hand into the vagina while the baby is in there. And what you're doing when you're putting your hand in is you're going to be aiming to shift the baby. So if the baby is up like this, like you shift the baby, then it can pass under the symphysis pubis. Or if with your suprapubic pressure, you can make the baby's shoulders come together, you're reducing that diameter and the baby may be able to slip out. The enter maneuvers are typically the ones that people who are not obstetricians or very experienced midwives are the least confident in doing. And so typically they're the ones that you would probably be your last go-to if you're someone who does deliveries very rarely. Unfortunately, nature is not selective in where emergencies occur. And so I've had a shoulder dystocia happen at home of a woman who had a precipitate delivery on her sofa, and her husband called the ambulance and said the baby's head is out, but the baby's body is not out. And by the time the ambulance got there, the woman had managed to deliver the baby, but the shoulder dystocia had gone on for 10 or 15 minutes. And that baby came into ED having CPR and had a really severe brain injury and did pass away, sadly, a few days later. So these things can happen anywhere. And mostly a fast birth, they usually go well and the babies come out fine. So please don't panic if it happens. But that's why it's important for everyone who, somewhere where someone could have a baby, is aware of what maneuvers to do if the baby gets stuck at the last minute. So delivering the posterior arm or shoulder. So as I said, in the also course, what we used to be taught was to put your fingers in here, travel your 2 fingers along the baby's arm until you get to the elbow, and then take the baby's wrist between the 2 fingers and flick it down over their face. And it's actually incredibly difficult to do that. And I have never had any success in trying to deliver the posterior arm in that fashion. What I have found really successful is to generally from behind, put a finger in the baby's armpit. So you've got one hand on top of the head, you put one finger in the baby's armpit, and you can then perform downward gentle traction, and that will deliver the posterior shoulder first, and let this shoulder then slip out under the pubic symphysis. And the other time I do this maneuver is if I've got a baby that's got really tight shoulders, that's cesarean section, because that's another situation in which we can be really tempted to pull on that head, and the head and neck are just not made for pulling on. So popping your finger under the shoulder, and you can do it from anteriorly as well, just gives you some way of putting some downward traction on the baby that isn't putting traction on the head and neck. This picture shows someone using a flexible, so it's been described to use a catheter or a pediatric suction catheter and poke that in and put it behind, and it's called an axillary traction sling. But that's not something that I've heard of as being commonly done in New Zealand. And I just don't think we tend to have things in our delivery rooms that are amenable to doing an axillary traction sling. But you always have your finger with you. So I would do it with my hand. Be ready for a flat baby. So exactly the same as with a chord prolapse. Chord pH drops by the minute. Typically, I was taught that it drops by 0.05 per minute. So if you've got a baby who's well oxygenated through labor and has a normal pH at the outset of their birth, and so a pH of 7.30, at the end of 4 minutes, that pH will be 7.10, and at the end of 5 minutes, it might be 7. And babies can survive pH drops down to around 6.8, 6.9, but that can be pretty life-threatening. So those are long minutes when you're in the room. And one of the issues can be that it can take a couple of minutes for anyone to declare the obstetric emergency and start doing the maneuvers, because everyone hopes the baby's just going to slip out as usual. So it is a situation in which calling the emergency and saying, I think this is a shoulder dystocia, and starting the maneuvers early can be really helpful. And around 80% of shoulder dystocias resolve with McRoberts and suprapubic pressure. So that's pretty good odds of getting the baby out without having to do anything too invasive. You need to be familiar with neonatal life support algorithms and have them up on a baby. Might be born there. Cord gases are ideal if a baby's had a shoulder dystocia, and documentation of the whole thing, including which shoulder was the anterior shoulder. It is relatively common to get birth injury with a shoulder dystocia, and the common injuries are fractured clavicle or fractured humerus. And it's really awful for the practitioner and the mum if that happens, and it's sore for the baby, but bones can fix themselves, and neonatal hypoxic ischemic encephalopathy or brain damage cannot be fixed later. So if you're going to have damage to something, a bone is definitely better to damage than brain cells. Important to debrief the woman and her partner, and important to be debriefed as the healthcare practitioner and be supportive, because if you've broken a baby's arm while delivering it, you're going to feel awful, but try not to. And there's a Bodies clip. So there was a UK TV show called Bodies that came out in around maybe 2004, 2003. And if you Google Bodies shoulder dystocia, there is an incredibly realistic simulation from that. In fact, I find it quite traumatizing to watch. It's in real time, and it's very realistic. And that is a very good simulation of what a shoulder dystocia looks like. There are some things called the maneuvers of last resort, and I think they actually do use one of those maneuvers in the clip. But the maneuvers of last resort are to push the head back in and perform a cesarean section, which is called the Zavanelli maneuver, clidotomy, which is deliberate fracture of the clavicle, or symphysiotomy, which is deliberate cutting of the pubic symphysis. But those are typically very rarely performed. So next we've got obstetric hemorrhage. This is a photo taken by a war photographer called Lindsay Adario, who started taking photographs of birth in developing countries. And this young woman is 18 years old and gave birth to the first of twins in her village. And the second baby just wasn't delivering. And so she got moved to a birthing center after about 24 hours of labor. And when she arrived there, she gave birth to the second twin, who was successfully resuscitated with CPR. And she birthed her placentas and then started bleeding, and the hemorrhage just didn't stop. And because they were in, you can see a very rural birthing center with no equipment. They had traditional birth attendants. They didn't have midwives. There was one doctor for this hospital with hundreds of patients. And by the time he arrived to help care for this young woman, she had sadly bled to death. And so certainly hemorrhage is a major cause of maternal mortality in other countries. And it's not difficult to imagine that it could be a cause of maternal mortality, even in New Zealand, if you're somewhere that is remote from healthcare. The one thing that we have that they don't have in developing countries, actually two things, are trained LMC midwives who are experts in birth and acute emergencies, and good access to drugs. So certainly drugs have revolutionized the management of postpartum hemorrhage. Hemodynamic changes that protect women against bleeding to death. So a typical adult blood volume in a non-pregnant person is 70 mils of blood per kilogram. So a 70 kilo adult has around 5 liters of blood in their body. In late pregnancy, there's a hemodilution, quite a large increase in your plasma volume. So the liquid component of the blood increases by about 50%, and a lesser increase in the red cell volume. So 20 to 30% increase in red cell volume. So that's why people get quite short of breath in late pregnancy. And there's something called a physiological anemia of pregnancy. So in late pregnancy, a woman will typically have 85 to 90 mils per kilogram of blood, which is 6 to 7 liters in a 70 kilo woman. So this is one situation. If you're going to have a PPH, you're far better to be a larger BMI person than a smaller BMI person, because you just actually have absolutely more blood in your body than if you're a little person. So it's quite interesting, because in obstetrics, we tend to measure the blood volume lost, but we don't usually tend to think about the relative amount of blood that the woman has lost. But if you were a little woman from Sri Lanka who was 45 kilos and you lost a liter of blood, that is going to be a lot more of your blood volume than if you were a larger woman with a BMI of 40 who also lost a liter of blood. So just the relative seeing on that woman that's in front of you. So pregnant women hemodilute, I think, so that when they have their blood loss at birth, it has less of an impact on them. A PPH is defined as a blood loss of 500 mils or more, and a severe PPH is 1,000 mils or more. But we know that if you have a surgical delivery, so a cesarean section, then the typical blood loss is probably closer to that 1,000 mil mark, and everyone loses 500 mils at least. So most women are able to withstand a blood loss of between 500 mils and 1,000 without of young people buffer shock really well, and they can handle quite a bit of blood loss before it manifests in hemodynamic instability. So beware, if you see a lot of blood coming out of someone, it will be affecting them. And typically how it manifests in young pregnant women is with a tachycardia initially. So pregnant women can lose between a liter and 1,500 mils. And the only thing that changes usually is their heart rate. So it'll go up 110, 120, 130. And once they get above 1.5 liters of loss, then they often will drop their blood pressure. And if someone who's been recently pregnant is tachycardic and hypotensive, you've got a serious obstetric emergency on your hands. So the causes of PPH are typically taught as being the 4 T's. So atonic uterus, so someone who's been in labor for a long time, or a giant baby came out, or she's a grand multip and it was her 5th or 6th baby. The uterine tone typically between pregnancies just doesn't snap back to what it was with the first pregnancy. Trauma, so someone who has a vaginal, vulval, or cervical tear or uterine inversion can cause a PPH. Retained tissue we all know about, and so that can either be the whole placenta is still in which case the uterus cannot involute. So after the delivery, the uterus is a muscle and it will tighten up. But we also know that just a bit of membrane or clot can stop involution. And it doesn't make sense that membrane, which is effectively like cling film, should be able to stop physical involution of the. And then least commonly, particularly as a primary cause of postpartum hemorrhage, is a coagulation issue. So if you did have a coagulation issue that was the initial cause of PPH, then it would either be someone who's been on Clexane in the pregnancy because they have a history of PE and they've gone into spontaneous labor, or someone who's got von Willebrand's. And usually we know about that, but very occasionally you might find someone who just tolerated really heavy periods their whole teenagehood and has gotten into pregnancy without having been diagnosed. The commonest time that thrombin or coagulation causes a problem with bleeding is after that first 1.5 liters, 2 liters. So once someone has bled a lot, they they consume all their coagulation factors and they'll go into DIC, which is disseminated intravascular coagulopathy, or as a lecturer in university said, death is coming. And women who are in DIC will start oozing blood from their line sites, and the blood that comes out just looks really watery. Once you've seen it one time, you'll never forget what that looks like. Some people like to put some extra T's on, and those are very, the first 2 are very hospital centric. So the extra T's are theater, right? But if you're in a rural place, you may not have a theater, but you might need to think, well, how am I going to get her somewhere with a theater? And tranexamic acid, which we have in most centers now, and that should be given early. So as soon as you recognize that there's excess bleeding, give tranexamic acid because it may save a life. And the other T is transfer. So for a tone problem, you need to stop the atony. So we tend to use fundal massage and bimanual compression of the uterus, get a line in. If you can, take some blood off, give some fluids, and give blood if you have it. So if you need to give more than 1 liter of IV fluids and you've got ongoing bleeding, or the woman is tachycardic and hypotensive, and you have blood where you are, and many rural places will have a couple of units of O-negative blood, then give blood even before you have any tests back telling you whether that's the right thing to do or not, because she may not tolerate the time that it takes to transfer to get her to somewhere where she can have a blood test to see if she needs the blood or not. Give as many uterotonics as you have. And give them relatively quickly. If you're still feeling like you need to give them, then keep giving them. And remember the tranexamic acid, and that can be given orally if that's what you have, or it can be given IV. And then a Bakri balloon is a big thing that's changed in the last 10 to 15 years of practice. And I would urge you, if you're working somewhere rurally where women are giving birth, to familiarize catheter. And so it's got as a catheter, and I've got a picture of one. They can be put in a woman who is bleeding and needs to be transferred. They can be put in without anesthesia. If you've got analgesia, then give her some. So if you've got some Severdol or codeine or gas and air, it's very uncomfortable to have somebody's hand and a balloon put in your uterus when you're awake. We would typically put them in theater with a spinal or a GAN, but I have done them in the room on women with no analgesia when I couldn't get to theater. And the main reason for doing the Bakri balloon or the bimanual compression is that you're applying pressure to the uterine cavity, which is where your bleeding is coming from. So this is what a Bakri balloon looks like. As you can see, it really does look like a giant Foley catheter, and it's got a balloon on it. It's got a channel for blowing up the balloon, and you blow it up until you feel the walls of the uterus. You're squirting it in, and it just squirts in, squirts in, squirts in, and then you start having to put pressure on to have it squirt in. Then you turn this little spigot to spigot it, and this channel allows blood to come out from the uterus. If you've put the bakri in and blood is still pouring out of there, then you've got a big problem, especially if you're not somewhere with a theater. But you can still apply bimanual pressure, and sometimes you might need to take the bakri out and just do bimanual compression. But a bakri is a way of putting that pressure on the inside of the uterine cavity and not having your hand in the woman for 3 hours if you did need to transfer her. And once you've put it in, you leave it in typically for 24 hours. And I've found this after probably will have a vaginal pack in, because of course it can deliver through that cervix. It's just had a baby pop through it, right? Other causes, trauma, you may need to do a quick repair where you are, or just put a pack in the vagina if there's a spurting vessel and you don't have someone there who's skilled or confident to repair it. Putting pressure on, putting a pack in will stop the bleeding until you get to somewhere that someone else can help you. Ensure the placenta is delivered and complete. If the placenta is still in, you probably could still put a bakri in if you needed to. I've never seen that done, but if you had to, it would be worth a try, whatever you can do to stop the bleeding. And if you've got a thrombin problem, they need to get somewhere with an anesthetist really quickly. But you give a gram of tranexamic acid, and you can repeat that one time if you're still waiting for an ambulance or a helicopter. But someone who's got a thrombin problem will need replacement with blood factors. So identify, stop, stabilize the woman, and keep the stuff. So make sure that we know in secondary care exactly how much blood loss there's been. Okay, I talk too much, so we're going to have to whiz through some of these slides. This is just a brief bit about obstetrics in ED. So we're a contentious thing, and everyone loves seeing a baby born, but boy, there are a lot of incident forms that get filled in when a baby accidentally sneaks out in ED, because it's out of everyone's comfort zone. And de facto in general, if you've got an ED, you've usually also got a maternity ward, which is where those children are meant to be being born. So in our hospital, there is a very strict flowchart and policy about who stays in ED for assessment and who should go to where the midwives are. And basically anyone who could be giving birth should go to where the midwives are, and that's accepted by maternity and it's accepted by ED. But there's always a little bit of argy-bargy, and someone who's described as having abdo pain, and someone in delivery suite who says, no, they can't come here, they need to be seen by the reg in ED. And every once in a while, someone will make a wrong decision. So in this case, this was a 24-year-old woman. It was her first pregnancy. She was 28 weeks and 5 days. She was a well woman, and I was the ONG reg on call. And in those days, we did 24-hour calls, so we could be at home on call. And I got a call from the ED nurse who was really upset because she'd rung maternity. There was this 28-weeker who'd come in with abdo pain and bleeding, and maternity had said, ring the registrar and she'll see her in ED. And the nurse was quite distressed. So some of my initial management was to agree wholeheartedly, but that I was coming to keep her in ED until I got there if maternity was saying no. And as I was driving into the hospital, I got a call saying, we think the baby is about to be born. So I said, please ring peds straight away, because a 28-week baby who's being born preterm is probably just going to come out. And actually, they could free birth that baby in the car park and it would just come out. So I would be the least useful person in this delivery. And the pediatricians are what are really needed. So the woman had not yet been examined by anyone. I had said on the phone, get the ultrasound scanner, call the midwives and say it's escalating, you need them urgently, and call peds and tell them to bring a transport incubator and someone should examine her. But I got there and everyone was politely clustered around this bed and no one had touched the woman. And so I did a speculum straight away and could see bulging membranes, and I did a vaginal examination and the baby's head was right there. So I knew birth was imminent. So I actually totally relaxed at that point, because just like when you're drunk and you know you're going to vomit and then you do vomit and you're like, oh, okay, that happened. when an emergency actually happens, sometimes you're just like, okay, this is happening and we're just going to have to go with it. So my main focus was on making the experience as pleasant for the woman as possible. And I said, oh, we're going to have a baby now and baby's going to come, and try not to push, please, because the peds weren't present yet. But they arrived really quickly. And as I had run into ED, I saw the midwives strolling down the hallway. And I was like, guys, hurry up. And one of the problems, of course, is that, you know, we cry wolf in healthcare sometimes, or that's the perception. And so the perception often on Birth Suite is that ED will try and sneak women who have a medical problem into maternity. And the perception in ED can be that maternity will not open their doors to a woman who clearly needs to be there. So we always need to work on our teamwork. And as the doctors, we just have to go where the care is needed. So it doesn't make such a big difference to our workload. So we never usually shut a door to where someone is. I just would rather be somewhere where I have lots of midwifery support if someone's going to have a baby quickly, because I want people who are skilled at neonatal resus to be with me. So these are the things that you need. Ideally, pediatricians. If you don't have those, a recent emergency that happened in a rural place, they got the pediatrician on FaceTime, and they had the pediatrician talking them through the resus. And so that's probably the next best thing that you can do. And something like FaceTime has really made a big difference, because they can see, the expert can see what you're doing and can say, no, that's not right, or can make their own visual assessment of how things are. You need a resuscitator transport incubator, you need a cord clamp, you need scissors, you need syntocinon, warm wet towels. And if it's a preterm baby, you need a little poncho to deliver the baby in. But if you don't have that, any clean plastic bag will do, including oven bags. Right. And so that baby got named Rush and did really well, and went to Dunedin and then went back to Southland. And I've actually bumped into the family several times, and they were very thrilled with their little baby. So that was great. Anyhow, I don't have time to go through sepsis now, I don't think, because we are out of time. But basically, the sepsis 6 is the key thing. And just to be aware that in pregnant women, it can be really difficult to diagnose sepsis, or in recently delivered women, because many of the things that are a sign of sepsis are also a sign of new motherhood. So being really tired and feeling a bit stink, and maybe being a bit slower and things like that. And when you've recently had a baby, people are really quick to be like, oh, that's normal, I had that, or you know, it's probably just because you just had a baby. So just have an index of suspicion. The ones that are really hard to diagnose are the ones that have had spontaneous vaginal deliveries and have had no obstetric input in their labor or delivery, because we all think, oh, well, they had a normal birth, so they'll be fine, there won't be anything wrong. But those are the ones that can tend to be diagnosed later, because no one's like, oh, well, they had a cesarean, so they might have an infection. Had a forceps, so they might have an infection. Just remember that any person who's recently given birth has had a large wound inside their body. So where the placenta was attached and then detaches, there's a large raw area that's got a vagina leading up to it. And vaginas carry a lot of bugs. And so anyone who's recently given birth is at risk of infection and sepsis. And so if you have anyone who feels very unwell, that is not normal, and they need assessment in a hospital. Okay. See, I definitely talk too much.
No, not at all, Kate. That was amazing. Your passion once again glows ahead of you. I'm having palpitations listening to all these emergencies. I don't want a story to go with that lot. Thank you.
No.
You're absolutely fantastic. Thank you. You have people from Australia. You've had a whole range: registrars, nurse practitioners, consultants, midwives, GPs. So yeah, you've really reached out to a range of people this evening. Thank you, Kate. Fantastic job again. Thank you. We just got some messages of thanks.
Oh, there's a question come up, hasn't there?
Oh, hold on, one's just popping in now. Let's have a look. Any role for trial manual removal of placenta or rupture of placenta and rural setting?
Yeah, so I think, again, this is an absolutely case-by-case thing. So if you've got someone with a retained placenta, what I would say is if you're in a rural place and you diagnose a retained placenta, which typically means that it's undelivered at between 30 and 60 minutes after the birth, then you need to make a plan for transfer of the woman to somewhere with an operating theatre. And because all of the women with retained placentas that I've ever had, where it's genuinely been retained and hasn't come when someone's put gentle traction on it, they've all had a 2-liter blood loss once we've managed to remove the placenta. So that's not something that you want to be dealing with in a rural or remote place. If there things that are totally safe to try in a rural place while you're arranging transfer, and once you've identified that that placenta is a bit slow to come, is so if you've been doing physiological management of the 3rd stage, totally fine to move to active management, give them intramuscular syntocinon or synthometrin if they don't have any blood pressure issues. Try the usual controlled cord traction, put a catheter in to empty the bladder just to make sure that's not affecting things, and try gentle controlled cord traction. If the cord is going to avulse, and so sometimes there's a velamentous insertion of the cord or just those flimsy cords that are going to come off, sometimes people are really reluctant to continue trying the normal amount of force that they would use for controlled cord traction in a routine delivery. And I would just urge you to have faith in yourselves and back yourselves. If a cord is going to avulse, it's just the same as if a cord is going to prolapse. It's going to come off no matter who's on the other end of it. And yes, it's so much more comfortable to make that statement as the O&G consultant. Lots of undelivered placentas is the one who will take the woman to theatre to fish that placenta out and isn't going to criticize themselves for doing it, but try to be really nice to yourself, because of course it's going to be in the woman's best interest if you can do controlled cord traction and deliver the placenta where she is without transferring her. That's going to be safer for her in general. So if you've got one of those cords where it feels like it's going to avulse, then I would persist with a routine amount of traction on that cord, even if it does then avulse, because you haven't actually made anything worse than if you start pulling on it. And anyone who's been in the situation knows that horrible feeling of where you're like, oh, you can feel it tearing a bit. But if you manage to pull it down so that half of the placenta is in the vagina, then you can usually retrieve that by putting 2 fingers in and grabbing the meat of the placenta, or putting a speculum in and using sponge forceps to put gentle traction on the meat of the placenta and deliver it. The one word for the wise is just to say that a cervix can look a lot like a placenta if you haven't seen a lot of either. So if you're not sure what you're going to be pulling on, I guess only use your fingers. Don't put sponge forceps on a big purple thing if you're not sure that it's a placenta. I would hope that most people who are delivering in rural places will have someone experienced with them to be a second pair of eyes. And if a second person looks and goes, yeah, I'm pretty sure that's placenta and not cervix, and you can put gentle traction on it with your hand, you really often can just grab the meat of the placenta and gently deliver it. And that might save a life, or it might save a woman a helicopter trip. And so I would say perfectly fine to do that. The other thing is if the baby has been born, the placenta is partially delivered or undelivered, and the woman is hosing blood, and you are far from anywhere else, then if you felt confident to do so, I would manually remove in the room. And that's not something that you're going to get sanctioned by anyone officially. But if you're watching someone die of bleeding to death from their vagina, then I think you have to try and get it out. And so what we do when we do a manual removal is we put our hand in. Ideally, you could just go into the vagina, you feel placenta and you can pull it out. But in the ones that genuinely are undelivered, we put our hand up through the cervix and we shear the placenta off the wall of the uterus. The woman would definitely need gas and air for this. And if you had some analgesia, you would give whatever you had, the best analgesia that you had. It's not something that I would do If she's not bleeding and you think it's a fully retained placenta and you can airlift her in a helicopter within 30 minutes to a tertiary center, then it's not something I would advocate doing electively. But if you had someone that was briskly losing blood and that was the only thing you could think of doing, then I think it would be a duty of care to try and deliver the placenta if you could. The other thing to be aware of that I didn't talk about much today is uterine inversion. So that's the reason not to put any more than gentle traction on the cord when you have got a retained placenta, because you can actually iatrogenically invert the uterus. So if the placenta in the wall of the womb, either a normal placenta hasn't detached normally, or a morbidly adherent placenta that's invading the wall of the uterus, and you pull on the cord, it will pull the uterus inside out with it. And the way of diagnosing that is if you put a hand on abdominally, you can sometimes feel a dip in the fundus of the uterus, or you may be able to see the fetal surface of the placenta stuck and out and wrapped around something, looking almost like a weird octopus wrapped around something. And typically the woman becomes profoundly shocked when the uterus is inverted. So it causes a very profound vasovagal response, a bit like cervical shock in women that are having a miscarriage, where their clinical condition is not compatible with the amount of blood loss that you've seen. And in that case, what you have to do is replace the uterus as quickly as possible manually if you can, and don't try to detach the placenta at that point. Just push the uterus back up and try and keep it up there, and you give uterotonics to make the uterus contract and stay up. And in that case, even if they weren't bleeding, I probably would give some tranexamic acid, because when you have a retained placenta that's genuinely retained, significant blood loss in my experience is usually in the future. And if you're lucky, it's in the future and will happen once the woman gets to tertiary care. But I've quickly learned in my career, because the anesthetist goes, is she bleeding? And you say no, and then they get very casual, and they always bleed eventually, those retained placentas.
Thank you very much, Kate. Good answer. Well, that's absolutely wonderful. People are just grateful for your advice and your information and guidance this evening. Fantastic. Thank you, Kate.
Great. All right. Hey, take care.
Thanks, Kate, and thanks, Kathy. That was great. All right, I'll end this session now. Thank you, everybody, for attending.
All right. Cheers.
Bye.
Bye now.